Okay, dear friends, good evening, everyone. I am Dr. Jambukeswaran, a PrepLadder's orthopedic faculty for you. So today we are going to do the recall session of INI-CET May 2024. Okay, so dear friends, can come for chatting. Am I audible and am I clear? Hello? Anyone, please? Hello? Oh, yeah. Thank you, Dr. Ibrahim Khan. Thank you, Angry Bird. Okay. Aisha Khan. Thank you. Yeah. Straight away, we will start with our first question, dear friends. And one happy thing, around 10 questions have been asked in INI-CET this year. Okay. So all the 10 have been covered in our YouTube sessions and everything is there in our notes. When I saw the question, I was feeling very happy and I'm damn sure that our guys and girls would have done definitely well. Okay. Yes. We will do. The first question. Okay. Yes. The first question, 75-year-old man presents with fracture of intracapsular neck of femur. What is the standard management done for this patient? The question, the age is 75 and the point, it is intracapsular because neck of femur, 90% it will be intracapsular, 10% can be extracapsular, very rare because anatomical classification when you recollect, subcapital, transcervical, basicervical, 3 types are there. Basicervical is near trochanter, so that can be extracapsular. The problem when it is intracapsular, 85 to 95% of people will go for non-union and avascular necrosis. So, surgery is the treatment of choice. Okay, surgery is must in 100% of the cases. So, when you read this option, when you see boot and bar cast, what his meaning is, this is called boot and bar cast, this is called derotation boot. Derotation boot. Okay, this is called derotation boot. And derotation boot is the treatment for intertrochanteric fracture, not for neck of femur fracture, especially intracapsular. Intramedullary nail is the treatment of choice for shaft of femur fracture, not for your neck. Okay. Russell's traction, because 2 types of tractions, it is there in our notes. Just you go and see in management or general management of fractures. Russell's traction is called skeletal traction. Okay, skeletal traction. And Buck's traction, there is a term called Buck's traction, B-U-C-K-S, Buck's traction. This is skin traction. Okay, skin traction. See, whether it is skeletal traction or skin traction, primarily this is used to reduce, it is used to manage a reduced post-dislocation hip. It can be used for shaft of femur before surgery to prevent muscle contraction. So this is not skeletal tractions, Russell traction, skeletal or skin tractions are not definitive management for any condition. So the treatment of choice for intracapsular shaft of intracapsular neck of femur fracture, a 75-year-old man is 100% hemiarthroplasty. Okay, hemiarthroplasty. That is the treatment of choice. Okay, yes. So, hemiarthroplasty is of 2 types, unipolar, bipolar. Unipolar, the example is your Thompson's prosthesis and Austin Moore's prosthesis. Nowadays that is outdated because the whole head, neck, stem, everything is one unit, and when the patient starts walking, it is going to cause degeneration of the acetabulum. So that is not nowadays used. Nowadays the hemiarthroplasty prosthesis of choice is modular bipolar. Okay, to be more specific, modular bipolar prosthesis. Okay, prosthesis. This is how. Because, dear friends, why I am, okay, sir, if in FMGE, LRR, you told to watch in LRR also, but it's not available for, okay, this we will discuss, Twinkle Tiwari, we will discuss this later. Because, right, we will finish this, okay, we'll finish this. See, modular bipolar prosthesis is very specific. Dear friends, why I am telling these names also? Because INI-CET is very important question bank for NEET. Forthcoming, we are having in June 23rd NEET exam. Similar type of questions may be repeated, dear friends. Should be very confident. intracapsular neck of femur fracture in an old patient definitely will not unite, will go for non-union avascular necrosis. So prosthetic replacement is a must. The prosthesis of choice is modular bipolar prosthesis. Okay, first question is over. We will move on to the second question. In Salter and Harris classification, type 1 fracture is through which of the following layers? A split in the layer. Okay, which layer is involved? Is this whole of epiphysis? Is this on resting layer? Is this hypertrophic or calcific layer? Is this mineralization layer? Okay, yes. Okay, so some has given answer A. I will tell you. Salter and Harris, type 1, complete separation of epiphysis from metaphysis without fracture. I am going to show you the slide. So it is there in our notes actually. It's there in our main recording. It's there in rapid revision. And in YouTube session, we had done this already. You see, the right answer is this. The right answer is this. Okay, I will show you. I'll show you. You see, Salter and Harris, type 1, complete separation of epiphysis from metaphysis without fracture. Whenever we come across epiphyseal injury, always we will think epiphyseal injury is due to trauma. That is true. Epiphyseal injury is due to trauma. Apart from trauma, type 1 epiphyseal injury can happen in rickets, scurvy, and chronic osteomyelitis infection. This question, this is there in all the standard textbook. For unknown reason they have not asked. I am expecting very soon in NEET or the forthcoming exam, if they want to alter all our causes for type 1 epiphyseal injury, except 4 causes are there: trauma, rickets, scurvy, osteomyelitis. You see which layer is involved? Hypertrophic or calcific layer is involved. Apley system of orthopedics. You look at the diagram, it is complete separation of epiphysis from metaphysis without fracture. Okay, good. Type 2 epiphyseal injury means epiphysis is separated from metaphysis carrying a small triangular bit of metaphysis along with it. You see here, this is epiphysis, this is metaphysis. Epiphysis is separated from metaphysis carrying a small triangular bit of metaphysis along with that, and that is called Thurston-Holland sign. 1 lakh time repeated MCQ. Thurston-Holland sign, type 2. And practically speaking, the most common type of epiphyseal injury is type 2. Most common type of, yes. So it is type 2. Yes. Type 3. Fracture is intra-articular and extends along the epiphysis, then along growth plate. Reproductive layer is involved. In first 2, only hypertrophic or calcific layer is involved, so growth arrest will not happen. In type 3, reproductive layer is there. If you don't reduce and fix it properly, this type 3 can go for growth arrest. That's the complication. Type 4, fracture is intra-articular and extends along the epiphysis, physis and metaphysis. That means all layers are involved. That was one choice, no? That is type 4. Unless otherwise you do open reduction internal fixation perfectly, this will cause growth arrest. Type 5 and type 6, worst prognosis, crushing of epiphysis. Whatever treatment you do, this will go for growth arrest. And type 6 is the latest addition, because even in standard undergraduate textbooks, they are given only up to type 5. Only up to type 5. That's called Salter and Harris classification. Latest thing, Rang has added one more type, type 6. So nowadays the classification system is called Salter, Harris and Rang classification. Very important, dear friends. This is the latest classification, Salter, Harris and Rang classification. So there is perichondrial physis lesion which is called perichondrial ring. So to our answer, which layer is involved in type 1 epiphyseal injury? Hypertrophic or calcific layer is the answer. Okay. If through whole of the epiphysis, it should be type 4. Okay. So the answer is B. Good. Coming to the third question, dear friends. A 26-year-old male presented with proximal 1/3 fracture shaft of femur. It is fracture shaft of femur. Proximal third, middle third, distal third, doesn't matter. It is shaft of femur fracture. What is the treatment of choice? Definitely you can't put an above knee POP cast. You can't above knee POP slab, hip spica. This and all useless, because you know femur fracture in proximal third, violent muscle pulls will happen. So definitely it will be totally displaced. The only treatment or treatment of choice, the best treatment is intramedullary interlocking nail. Intramedullary interlocking nail. When it is old generation nail, first generation nail was called intramedullary nail. In intramedullary nail, you won't usually lock, just you will have just an intramedullary nail. The nail passes through the proximal fragment, and the nail passes through the proximal fragment, goes through the fracture site and comes to the distal fragment. Okay, there is no locking proximally. For example, you see this is the femoral shaft. Fracture has happened. Okay, please. Yes, femoral shaft. Okay, fracture has happened at this level. Okay, fracture has happened at this level. This is proximal fragment. This is proximal fragment. This is distal fragment. I am introducing a nail through the proximal fragment, through the fracture site into the distal fragment. I am not locking anything. This was called the old generation K nail. This was called the old generation K nail. K stands for Kuncher. Kuntcher. Kuncher's nail. This was the original nail. The problem when I just put an intramedullary nail, when I ask the patient to walk, proximal fragment moves in one direction, distal fragment moves in another direction. So this area can go for non-union. Okay, this can go for non-union. To overcome this, what they have done, they will put 2 screws proximally, 2 screws distally. So intramedullary nail has become intramedullary interlocking nail. And this nail name is not given in your undergraduate textbook. K nail name is there. This nail is called Gross-Kempf nail. Gross, K-E-M-P-F-T. Gross-Kempf nail. Otherwise called GK nail. This is the treatment of choice for fracture shaft of femur. That is the treatment of choice for fracture shaft of tibia. Because both are weight bearing bone, the best management is with intramedullary interlocking nail. Okay. Yes. Okay. So we'll move to the third question. Which of the following, okay, chats, okay, which of the following is an osteoporotic fracture? Which of the following is an osteoporotic fracture? Right, you see vertebra, subtrochanteric, glenoid, midshaft. Midshaft needs some force. It can be pathological fracture, but mostly in young adults in road traffic accident, it can happen. Glenoid needs high energy. Subtrochanteric fracture needs very high energy. Usually osteoporotic fracture, this is called pathological fracture, most common site is vertebra. And this fracture is called wedge compression fracture. Wedge compression fracture. Wedge compression fracture. Okay, I'll just show you a classical example of wedge compression. You see this lumbar vertebra 1, 2, 3, 4 here. When you see totally there is a wedging. Okay, the loss of the vertebral height, you see here I had drawn. So there is loss of vertebral height. This is called wedge compression fracture. And okay, wedge compression fracture. And this is a pathological fracture which follows osteoporosis. You know what is the most common mechanism in our OPDF friends in our country? Patient will be traveling in a government bus, especially last seat. Driver is driving the bus around 80 km speed. He is sitting in the last row. A speed breaker is there. The driver didn't notice the patient. Everybody sitting in the last row jumps and sits down. That day nothing will happen. Next day he will come to my OP with low backache. When I take a lateral view x-ray, exactly I will see a fracture like this. That's called wedge compression fracture. Most common predisposing factor is osteoporosis. Very rarely this can be due to certain malignancies like secondaries and multiple myeloma. Okay, yes. Okay, yes. You see, coming to the next question, identify the fracture shown in the image. This is the image, and all the students, everybody, the review, everything came as they had given only the AP view. When you carefully note here, I am able to see a fracture line like this. Okay, so this is the patellar bone. Okay, they should have given a better view, but this is what I heard is given in the exam. So this is a case of patella fracture, because in tibial condyle no fracture is there. In hemarthrosis you can't see any fracture. What is the radiological change you can see in hemarthrosis? This intercondylar notch, this will be widened like this. It is there in our main recording, and in YouTube also I had done. Widening of the intercondylar notch is the radiological feature of hemophilic arthritis, that is hemarthrosis. Okay, it won't show you any fracture. Okay, so the right answer here is patellar fracture. Patellar fracture, when they ask, it is divided into undisplaced, displaced. When displacement is less than 2 millimeter, it is called undisplaced fracture patella. When displacement is more than 2 millimeters, that is called displaced fracture patella. Why to classify like this? Undisplaced fracture patella, treatment of choice is cylinder cast, immobilization of the knee joint in a cylinder cast. Displaced fracture patella needs surgery, and that is called Martin's. The treatment of choice is called it's called Martin's tension band wiring. Okay, I will show you in the next slide. I will show you. See, so that is, and according to the fracture pattern, transverse fracture, oblique fracture, comminuted fracture, vertical fracture, the most common type is always transverse. Second common type is comminuted. Okay, you see, I am going to tell you, this is the reserve question. The best view to visualize patella is not your AP or lateral. This is the view. So you see the knee joint is flexed to 45 degrees and X-ray beam passes from here to the patella like this. Okay, just you zoom the app and you just see. This view is called skyline view. This view is called skyline view, otherwise called axial view. This is otherwise called merchant view, MERCHANT, merchant's view. Merchant is name of a person. Okay, merchant's view or skyline view or axial view is the view of choice to visualize correctly the patella. Instead of 45 degree flexion, when you flex the knee joint to 90 or 110 degree flexion like this, you will get a picture like this, and this view is called sunrise view. This view is called sunrise view. These two views are excellent views to visualize. You see how patella is seen. Here is also a fracture patella is seen. How clearly it is seen. So in the exam, if they ask a question, dear friends, what is the X-ray view of choice for to diagnose fracture patella? It is skyline view, merchant view or axial view, otherwise sunrise view. The difference is 45 degree flexion is called skyline. When you flex the knee to 90 or 110 degree, that's called sunrise. See, you see the patella is rising like a sun in the horizon. So this is called sunrise view. Two excellent views. Okay, once you are diagnosed a displaced, undisplaced fracture patella, I said the diagnosis, the treatment of choice is cylinder cast. If it is a displaced fracture patella, it is called Martin circumferential tension band wiring. Martin circumferential tension band wiring, TBW. 1 lakh time repeated MCQ. Just what is that? You are putting two K wires through proximal pole of patella through the fracture site into distal pole, and you are just tying that with the stainless steel wire in the form of figure of 8. Okay, so this is called Martin circumferential tension band wiring. But if the patella is very much shattered into pieces, into many pieces, special attached many pieces, that's called comminuted, highly comminuted fracture patella. You can't reconstruct. You have to go for what is called patellectomy. You have to go for patelectomy, right? And in patelectomy, the treatment, the patelectomy goes by a name, and that is called West and Soto Hall's procedure. It's called West and Soto Hall's procedure. Soto Hall procedure. They may ask this question. So far, they have not asked what is the name of patelectomy. Patelectomy is called West and Soto Hall's procedure. That's the treatment for highly comminuted fracture patella. And I'm telling you, dear friends, when you do patelectomy, what will happen? Nothing will happen. Patient can walk and climb the stairs well, can climb the stairs down, can squat, everything he can do. Last 10 degree extension is not possible if patella is removed. That's called extensor lag. So the only side effect of patelectomy is extensor lag. Okay, good. We'll move on to the next question. You see, which of the following is a zone of calcification? So this is a histopathological image of a physis, growth plate, physis. It is there, the same thing in vertical fashion. It is there in our main recording. It is there in our notes. There in PrepLadder notes. You see, Which are the following zone of calcification in this image? A, B, C, D. They had given this in horizontal fashion. You should have that in vertical fashion. A is the zone of calcification. Provisional, it's called zone of calcification. It's others called zone of provisional ossification. I will show you. Okay, I will show you. Right, you see, 5 the growing structure consists of flat portions adding length to the bone and circumferential giving the width of the bone. 5 is divided into 4 zones. These zones are respectively from epiphysis to metaphysis, from epiphyseal end to metaphyseal end. This zone is called reserve zone. This zone is called reserve zone. This zone is called zone of proliferation. This zone is called zone of hypertrophy. The last one is called zone of provisional ossification. Other is called calcification. Okay, 4 zones are there, right? So this is the same picture they had given in this horizontal fashion with a different color. Okay, so this is zone of provisional ossification. Very good. Coming to another next important question, several times discussed question. Definitely all of you would have done it correctly. I have no doubt. Okay, I feel 10 ortho questions. I think most of our guys should have done it well. Okay, so almost straightforward. A CT scan of a 22-year-old male was done as shown in the image below. Identify the condition. Okay, number 1. You see? Yes. Dharani Dharan and 715 Amit in Akifa Zara Suraj Roy. All of you had given a wonderful right answer. The X-ray, this MRI shows a classical picture of chronic osteomyelitis. Marvelous, guys. All the best. Superb answer. You see here, investigation, when you see this X-ray, what are the X-ray is enough to diagnose chronic osteomyelitis. Okay, what are the things it will show? First thing you see here in this view, the cortex is very irregular. The cortex is very irregularity of the cortex, cortical margins. So the cortex appears very irregular because of repeated periosteal reaction. And sequestrum, a dead bone is seen which is more opaque. You see, it's more opaque than living bone. Small holes I am able to hear. This is called cloaca. These holes are called cloaca. Only through cloaca the dead sequestrum comes out through the sinus tract, and it is through the discharge it will get discharged out. That's called cloaca. Very important thing, dear friends, in chronic osteomyelitis, when you see I am able to see a medulla. This black color line is a medullary canal, and the thickened thing is cortex. In one place I am not able to differentiate which is cortex, which is medulla. That's called loss of corticomedullary differentiation. The only diagnosis in the whole world is chronic osteomyelitis, dear friends. Okay, there is no second differential diagnosis. Loss of corticomedullary differentiation. You look at this MRI image now. In this place, you don't know which is cortex, which is medulla. You don't know this place, you don't know which is cortex, which is medulla. Corticomedullary differentiation is lost. I am seeing all these thickened things are sequestrum. Right? Coming to investigations, additional points I want to teach you, dear friends. Sinogram, is it important? Very important. When there are multiple sinogram may be done. Radio opaque dye is injected and read with X-rays on CT. Why to do sinogram? Because, okay, yes, see, yeah, 715 Amit had given, yes, thank you. You see, sinogram, when there are multiple sinogram, why it's a must, dear friends? You see, the treatment of choice for chronic osteomyelitis, apart from removing the dead bone, that is sequestrectomy, and making shallow saucerization, the treatment of choice for chronic osteomyelitis is sequestrectomy and saucerization. Apart from that, you have to completely excise the sinus tract, dear friends. Why? Because sinus tract is lined by squamous epithelium. When you leave like that, later on, some patients may develop squamous cell carcinoma, which is a very important complication of chronic osteomyelitis. So sinogram is a must. Sinogram is a must. Then comes CT scan. CT scan, major, it is just superior to your X-ray. That's all. MRI provides an acute determination of extents of pathology in bone and soft tissue. It shows sinus tract also. It is not invasive investigation, but MRI showing you sinus tract also. In that way, MRI is a superior investigation. Okay, right. Then we will move on to the next question. Identify the structure marked in the image below. Okay, this several times last year NEET also they have asked the same question. I don't know what is very interesting in this rib. Always they are asking, and it's easy for us. This is an AP view, anteroposterior view. When you see an anteroposterior view, when you see transverse bones like this. This is the posterior rib. When you see these oblique bones, this is the anterior rib. An anterior rib always it won't complete because it goes for costochondral junction. Costo means cartilage that you can't see in X-ray, so it look like an incomplete bone. When it is complete and transverse, this says it is the posterior rib. So they had asked this, what is this? This is obviously a posterior rib. Okay, posterior rib. Okay, good. Now, which of the following is a complication of intermittent administration of teriparatide? This is a tricky question, dear friends. This is a very tricky question. I don't know how many of you got tempted and ticked osteonecrosis of jaw. I don't know. Okay, I don't know. Okay, can I see the chat? Can I see the chat? Yes, marvelous. Okay, Roy, AGT, Mithukumar, okay, Sildenafil. What a peculiar name, man, Sildenafil. Okay, and everyone, all of you had answered it correctly. Marvelous, guys. That's what our guys, marvelous. You see here, osteonecrosis of jaw is not caused by teriparatide. This is caused by bisphosphonates. This is caused by bisphosphonates. Bisphosphonates and denosumab, monoclonal antibody. Denosumab we are giving for giant cell tumor, no? The denosumab, which increases the maturation time of osteoclast. The denosumab and bisphosphonate are recorded to cause osteonecrosis of the jawbone. Your teriparatide is used to treat medicine-induced osteonecrosis. Medicine-induced osteonecrosis caused by medicine. Which medicine is inducing osteonecrosis of the jawbone, mandible? Your bisphosphonates and denosumab. So, drug-induced osteonecrosis of the jawbone treatment given is teriparatide. Okay, it won't cause net bone loss. Net bone loss is osteoporosis. Teriparatide is a drug of choice for postmenopausal osteoporosis and corticosteroid-induced osteoporosis. So, this is not the answer. Osteogenic sarcoma is the right answer, dear friends. Because studies have proven that osteogenic sarcoma is a rare complication that can be induced by teriparatide, especially in animal studies. That is why very clearly given what are the contraindications for teriparatide. Bone tumors. Generally, they are using a word, the textbook. And osteogenic sarcoma can be caused, is a risk factor. It can be caused by teriparatide. The evidence is Goodman and Gilman. Textbook of pharmacology. Goodman and Gilman. Very clearly the answer is given. So, osteogenic sarcoma. Subtrochanteric fracture is not caused by, okay. All of the following regarding ankylosing spondylitis are true except the last question, dear friends. And it is there, exactly it is there in our notes. I am going to show you the slides in the next thing of our PrepLadder notes. It is there, you see. Occurs before age of 20, never age of 40. True. More common in males, 100% true. HLA-B27 is positive in more than 90, 100% true. Non-erosive arthritis is false. It causes erosive arthritis. You see here, you see the prevalence of ankylosing spondylitis has a clear correlation. This is our notes. This is our PrepLadder notes. HLA-B27. You see the percentage. 80 to 95% of patients with ankylosing spondylitis will have HLA-B27. Very latest thing that says that one intestinal Klebsiella is implicated in causation of ankylosing spondylitis. When I am discussing this in YouTube, I said that this is an unasked question. If at all they want to ask a new question in ankylosing spondylitis, this can be. So this can be asked in NEET. Dear friends, intestinal Klebsiella is a proven risk factor for ankylosing spondylitis. Very new concept. Very new concept. Okay. Yes. Then pathology, it undergoes 3 stages. First stage is inflammation. Second stage is bony erosion. This is what we are given. Non-erosive is wrong. Definite bony erosion. Third thing is spur formation. That's called syndesmophytes. Okay. You are seeing this spur, claw-like spurs. So spur formation. Right. And you see here, men are affected 3 times more common than women. That's the statistics. Typical age is 20 to 30 years. Never after 40. So it's correlating. Right. So we have completed all the 10 questions of our recall session. I hope most of you are done well. All the best, dear guys. And our main exam again, our 23rd, June 23rd is our NEET. Focus your full attention. Focus your full attention. This INI-CET is a good exam. It's a model exam for us. Many of us, the high chance may get this in this exam itself. No problem. But again, NEET with a lot of space is available. So what I am telling you, these INI-CET recall, these INI-CET questions are very important. Go through that, because there is a chance that one of my, since I am in a medical college, my UG guys, many got selected for MS Ortho on government colleges. They said that last year 18 questions were repeated. So these are all small tricks, dear guys, and I pray to my God very sincerely, all my guys and girls should win this time. Thank you so much, dear guys. Thank you.